our first presenter today, Mr. Tony Lai. He's a clinician and researcher at the Sydney Children's Hospital Network and the University of Sydney. He is currently the Senior Antimicrobial Stewardship Pharmacist at the Children's Hospital at Westmead and a clinical lecturer at the University of Sydney School of Pharmacy. He has had expert editorial roles for the Therapeutic Guidelines, Australian Medicines Handbook, the Australian Injectables Handbook, and the Australasian Neonatals Medicines Formulary. His research includes PKPD, TDM, and pediatric infectious diseases, and we're really lucky to have him here today to talk about antifungal dosing in kids.
Thanks, Amy, for the opportunity to present. So I thought we'll start off by we'll be focusing on antifungal dosing in kids, but I'll start off by I guess what the problem is and the possible solutions to the issues. So first of all, the problem. So pediatric clinicians are constantly challenged because whenever a new drug gets TGA, FDA, EU licensing of an indication, it's exclusively in adults because exclusion criteria will often have less than 18 years of age. And then subsequent to its release in adults, it takes about 8 to 10 years for some research in peds to help give us an idea of what's the best dose to give for kids. But these papers are often done in an open label fashion, and there's no comparator, such that the primary endpoint is a PK endpoint. Like, are we getting the same AUCs, peaks, troughs to the exposures of voriconazole in the primary adult study? And the secondary endpoints, toxicity and efficacy, but never really analyzed to a high power level, or recruited to a high power level in terms of patient numbers. So this is constantly what we're struggling with, to having to deal with quite low level evidence studies to guide dosing in kids, and this is not unique to antifungals. It's basically pediatric practice in a nutshell. And on top of that, the other layer of the problem is children are not small adults, and there's a dynamic shift in all the pharmacokinetic parameters of absorption, distribution, metabolism, and elimination throughout the development, especially in the first 2 years of age, such that the stomach acid shifts, the total body water percentage fat shifts, hepatic clearance usually becomes of adult levels at around 2 years of age, and the kidneys really take a good 2 months to develop to similar levels to that of adults. And why does this matter? Certainly for antifungals, is that antifungals is invasive fungal disease, IFDs, has a significant incidence in most pediatric facilities that really deal with the hematology oncology population. So you can see here that the incidence is not low, and certainly higher within the higher risk relapse acute lymphoblastic leukemias and AMLs, which is our bread and butter hematological malignancies that are treated in pediatric hospitals. And these come with a significant mortality, and that's even despite best treatment that we have on our formularies in our hospitals. So the possible solutions really to overcome these issues of making sure we're giving the right dose, similar to those primary adult studies, is TDM. So TDM is definitely something that pediatric clinicians and institutions are very familiar with and do them more routine than I feel in adult practice, just to fill in those evidence gaps and levels of uncertainty that we're not aware of. Because um, those studies that were done 8 to 10 years later in peds, um, are often not the type of children that we are treating. We're treating very atypical patients in terms of PK. They could be critically ill. They could be on ECMO. They could be on renal replacement therapy, renal impaired, obese or underweight. So there's a large range of dynamic intra-patient variability to having to overcome. And TDM really helps with that. And I guess the evolutions of these solutions is moving away from trough-based TDM to more sophisticated methods, which I'll go into over the next slide. So to really understand this problem, we just need to know the actual extent of the problem. How are we doing? How are we doing with antifungal dosing? Um, and to sum it up, the bottom line is that in terms of azoles, it is broken. So Jan Willem, which we claim as an Australian now, he hails from the Netherlands, did a really interesting study looking at fluconazole exposures in critically ill patients and looking at a range of different subpopulations of pediatrics. There are variable exposures, some of which are far below the target PK we would want in classical dosing. So here we can see a range of doses megs per keg and targeting a trough of above 11 to 12 milligrams per liter, which is a surrogate measure of AUC of around 400, which is just target PK/PD index for fluconazole. And you can see here our cancer kids are really underperforming at product information dosing. And here's an example of, the types of dosing that we would recommend both in Australian guidelines and dosing references we use, certainly in Australia, where there's a classical loading dose 12 and then a drop of 6, but really we should probably be considering giving 12 throughout the whole treatment period, certainly in these type of patients in the immunocompromised host, critically ill, and whether or not TDM fills in that gap. So that was fluconazole. Now let's look at itraconazole, and we've got some colleagues in Perth who looked at the giving the fancy itraconazole, which supposedly has better absorption than the capsules and the suspension, and really like quite poor performance in terms of target PK. And this didn't really improve despite with TDM, where only 40% at starting doses had, well, one of 60% had sufficient concentrations, but um, yeah, it didn't really improve that much with TDM. And we did that locally at my site, looking at posaconazole, where 1 and 2 kids starting on doses that you find on online references only give you 50% target attainment, and it doesn't really get much better if you do some TDM with it. Some colleagues from the Royal Children's Hospital also looked at voriconazole. Same story, poor target PK/PD with our PK modeled starting doses, really high doses that we give for children. 8 to 9 megs per kg, 12 hourly, which is much higher than what you would give an adult. And really, we're not really hitting the mark with that type of dosing. And even after you've done TDM, your percentage target attainment hasn't really improved that much. So you're in the practicalities and implications of this in practice is that we're having to do a lot of episodes of TDM, more bloods, waiting 3 days, do more bloods, so a lot of interpretation, and you can see the impact on length of stay and potential hospital bed days on that. And I haven't really published this, but we had a Dutch summer student look at this for us, and really, our what we see at Westmead Children's was quite similar to what we've seen in Melbourne at Royal Children's Hospital. You're not really getting good target attainment with posaconazole despite getting multiple episodes of TDM. So why is this? Um, so yeah, it's a consistent theme here, and of azole dosing in children being broken. So why is this the case, and what can we do to fix this? And an implication of this, certainly if a patient has confirmed or proven invasive fungal disease, certainly in my institution, we're having to overlap treatment with treatment doses of ambisome, 3 mg per kg, even 5 mg per kg, waiting until therapeutic concentrations of azoles. So you can see the AMS impact of that, of, additional cost and giving a very nephrotoxic drug just because we're not dosing them properly. So what can we do to improve? So there's certain hacks, certainly with posaconazole, that have been described in the literature, with the increased frequency of dosing, vitamin C, avoiding PPIs, giving it fat food. More recent publications that you can actually crush the tablets and get decent levels, despite the product information saying, "Oh, do not crush," because it's a modified release, special coated tablet, but you can get away with decent levels by crushing them. And this is described in it. You can find this in MIMS now, Don't Rush to Crush. And certainly we've found this has been true locally at Westmead Children's Hospital. Um, One study I wanted to refer to, I guess, is Ikaya et al. In TDM journal, where they have a there's this posaconazole, especially has a satural absorption such that if you give doses greater than 24 mg per kg 6 hourly or above 300 mg per dose, you're not going to get further better target attainment. So this is a really busy slide, but basically you can see here you've got 4 different groups of diarrhea, no PPI or with PPI. And then you got frequency of dosing comparisons, and also, uh Ye no, I posted that twice. Hold on. Oh, yeah, sorry. Um, so you can see here, uh, the effect of diarrhea and PPIs, but, as soon as you get doses, well above 300 milligrams per dose, even, more frequently, you're not getting better than 80%, which is shown by this top far right green line. And on the x-axis on the right one, you got dose mg per kg. So you see here around 24 mg per kg, you're not really getting further improvements in dosing. That's probably when you should consider another drug. For voriconazole, a hack I like to do is to play around with the CYP2C19 interactions and add omeprazole, which has been shown that in both pediatric and adult literature to improve levels. But the challenges with voriconazole, as we all know, that it's got nonlinear PK with the satural absorption, lots of drug interactions with even CRP, and this CYP2C19 polymorphism and autoinduction as another layer of complication. So, looking at possible solutions of modern form precision dosing, I like to throw in a patient case to kind of make this more relevant. So we had this 8-year-old girl who came in with penetrating head injury with a fencing spike. Had surgery, went home, came back, fevers. The wash up was that we grew Scedosporium apiospermum on CSF. Very nasty bug with limited susceptibilities, and most ID AMS farms should know that this is classically resistant to amphotericin B. Um, so we started on, well recommended doses according to the product information, based on pediatric PK monitoring, giving high doses, and we're getting low levels. And I guess one thing to note with voriconazole is because of its satural absorption, you need to do really small dose increases because you don't want to reach that saturation point and overshoot the mark. So we did minor dose increases, got therapeutic levels, and continued to do TDM throughout the patient's admission, noticing this gradual decrease in VORI levels. And this is what we would see as a phenomenon of autoinduction, classically around 1 to 2 weeks of voriconazole treatment. So then we had to play around with increasing a dose, and then I overshot the mark by increasing it too much, getting a level of 14.9 despite a very modest dose increase. So that's so this is saturation happening in front of us and autoinduction happening in front of us with classic TDM, trough-based TDM. Um, she was getting quite significant CNS toxicity, and we just had to withhold the dose, let it all clear out, and then um, I tried playing around with a Bayesian forecasting program called Inside RX. We're trying to model a better dose, noting that we have all this PK data to input to model. So here is kind of like the output of Inside RX, but the beauty of Inside RX is you can choose multiple PK models. So here's Michael Neely model. There's like 4 other models, like Freiberg's model, and it, it is quite customizable compared to other MIPD programs where you can place the level of bias to the more recent dosing, or place more bias onto your patient's PK rather than the a priori PK model PK, and it gives you a rating of model fit. So here we can see quite a decent, good model fit, suggesting that 120 milligrams IV 8 hourly gets decent AUCs of 93 with a trough of 1.6. But what I love about Inside RX is it actually gives you a nice neurotoxicity risk, according to the dose, which I don't really see other programs doing. And yeah, so I tried that dose, and we were not too far off the mark. So we got 2.2 when it was predicted to give 1.6. And then we did an IV to oral switch. Now, this is quite specific to peds, is that compared to adults VORI is quite bioequivalent, so you give 1-to-1 dose change. But if you're doing IV to oral switch, you need to give 1.5 times because it's not bioequivalent, and that's what we saw in our patient here, and we're getting decent levels after that. So that's MIPD as a case study, but how can we refine this to do a better job? And certainly, I think we should increase our understandings and apply it to voriconazole, noting that its significant polymorphisms of there are, a cohort of patients that have ultra and fast metabolizers. The ultra ones you probably shouldn't even give vori in the first place, but the fast ones probably just need higher starting doses. And that's what we're trying to answer as a clinical research question as a group, led by Jason Roberts and Thierry Reduce. Now, Jan Willem's done this really nice. It was only a comment paper in the JAC, but I really loved it because when he showed it to me, it was actually quite applicable in giving you an idea of the phenotype of a patient, whether or not they're a hypermetabolizer or normal metabolizer by measuring a voriconazole metabolite. So you measure the primary drug and the metabolite, and you can have an idea of where they sit in terms of metabolizer. And there's been other research showing that you can use a metabolic ratio. There are complex algorithms here, but I think this needs to be. I don't want to delve into the weeds of this, but basically, this is ideas of a new study. I think that should be validated because it is quite interesting. Because to get a pharmacogenomic test of a CYP-TC19 can be limited by the labs that are close to you to do it, and it can be a bit of a delay, 1 to 2 weeks, and it can be quite costly. So therein lies the combination of MIPD, pharmacogenomics, and using metabolites to have a better idea of getting a voriconazole or azole dosing more on point. What about the other azoles? What about the other antifungals? Sorry, I've focused a lot about azoles, but we need to think about whether or not there's a similar story happening with ambisome or amphotericin B. And that I really feel like there is a bit of gap in research here because there is a lack of clinical data, certainly in the amphotericin space. We're basing this on all very preclinical data where, David Andes' group has done a really nice narrative review looking at what are the targets here. And as we all know, triazoles or AUC of MIC, PKPD index drugs. But yeah, ambisome, bit of a gap, and then echinocandins in the aspergillus space is a bit of a gap. But basically, ambisome, there are early descriptions that it could be a peak concentration for efficacy and an AUC for nephrotoxicity, but it needs more validation. A similar story here with the echinocandin has got to hit quite a large Australian cohort of co-authors here, but basically they've done a nice narrative review looking at whether or not this is the same story with the echinocandins, but probably needs more research in this space. So take-home messages. Yeah, azole dosing is certainly broken in kids. Where appropriate TDM is mandatory. And we need to be able to discern the differences of what makes posa so special with the saturated absorption and voro so special with the saturated metabolism, autoinduction, and CYP2C9 polymorphisms. But yeah, clearly voriconazole is the most challenging drug. I hate it when it gets started because it knows it's more work for me down the line. Um, and whether or not we need to consider more sophisticated methods of TDM using pharmacogenomics and metabolites, and watch this space for these other classes of drugs. Cool. Thanks, Amy.
Tony, that was brilliant. Thank you so much for that whirlwind tour. Um, has anyone got any burning questions? I'd allow one burning question. Otherwise, we'll let Tony get out of the hot seat. Can't see anything coming up. So thank you very much for that. And yeah, we'll let you get on with life. And thank you so much again.